Hello everyone, this is Dr. Hashem Abu Serhan. I will present today a talk about Intumescent cataract management, how to tackle Intumescent cataracts, all the updates and novelty in this lecture. I hope that you will find this lecture very useful to your career. So I don't have any financial disclosures to declare. Intumescent cataract in general is a challenging cataract, and white cataract represent about 13.5% of worldwide cases. This is one of the papers about the prevalence of white cataract worldwide. However, not all white cataract is Intumescent cataract. Some of the white cataracts are hard cataract, some of them are Intumescent cataract. Some of them are soft cataract. It depends. Why it's a challenging cataract? Because there is always a risk of rhexis margin loss. And this rhexis margin loss can extend to the posterior capsule, leading to vitreous loss and dropping of the lens material to the posterior segment. Also, there is a risk of poor capsular support for IOL implantation. Also, there is extensive intraocular manipulation that can lead to corneal endothelial damage and loss of the endothelial cells. Also, there is extended surgical time. So, it's a challenging cataract that needed preparation and need good mind before starting the surgery. One of the papers published in Indian Journal of Ophthalmology discussed the preoperative criteria for the Intumescent cataract, and they highlighted 3 points. The first one is the presence of a shallow anterior chamber, which is a plus minus. Not all Intumescent cataract will have a shallow anterior chamber. However, most of the Intumescent cataract can have a shallow anterior chamber. The second thing, which is the most important definition of this criteria, the presence of fluid vacuoles or sectoral markings in the anterior cortex and the slit lamp. You should always be able to evaluate the intumescence on the slit lamp clinically preoperatively, not using any other investigations. You should see how is the intumescence pre-op by evaluating these fluid vacuoles and sectoral markings in the anterior cortex. In addition, the presence of multiple internal aquatic reflection on A-scan. These multiple spikes indicate multiple fluid compartments. So, in Intumescent cataract, usually you cannot see the back of the eye, the retina. So, all you need to assess the back of the eye doing P-scan to assess if the retina is flat or something, is there any masses or detachment or something. But always ask to do with the P-scan, A-scan. And when you see multiple spikes in A-scan, multiple internal aquatic reflections, these representing a presence of fluid vacuoles, which indicate that this cataract is intumescent. There is a good hint represented by Dr. Uday Devgan, the well-known cataract surgeon, that the more bluish color, the more liquefied cortex, the more Intumescent cataract is. And the more yellowish color, the more hard cataract, the less liquefied cortex and the less Intumescent cataract is. Because when you go to the yellowish light, it means that there is fluid resorption happening, so there is no Intumescent. However, the more bluish, this bluish tint reflecting fluid vacuoles in the cortex. So if you see a patient with a bluish yellow-white cataract, you may predict that this cataract is intumescent. This is a picture of white cataract with a bluish tint, which these represent the liquefied cortex, and you can here see the sectoral markings in the anterior cortex and the fluid vacuoles. Why also is Intumescent cataract challenging is due to the Argentinian flag sign. This is a well-known described complication due to the Intumescent cataract. And the mechanism of this complication is due to the raised intralenticular pressure. This accumulated fluid inside the lens capsule raise the intralenticular pressure. So there is high intralenticular pressure inside the lens. And there is also fragile capsule. This fragile capsule, most of the patients usually are elder, so it's due to aging process, their capsule is fragile. So this high intralenticular pressure, okay, and pressure in the anterior chamber, so there is a pressure gradient from the inside of the lens to the outside of the lens, causing the anterior capsule to run out, so you will lose the rhexis. So once you do the initial neck for the anterior capsule, the lens will decompress, and there is this intralenticular pressure and anterior chamber pressure difference gradient lead to rhexis extension radially or biradially. If it's extend biradially, it causes what is known as the Argentinian flag sign. And this Argentinian flag signs incidence of 8% to 28.3%. So it's common, not rare complication. So you need to prepare before doing Intumescent cataract all the maneuvers that we will describe in this lecture to overcome this complication. This Argentinian flag sign was named by Dr. Daniele Mario Pironi, who first described this complication, and his video won the award in 2000 American Society of Cataract and Refractive Surgery and the European Society of Cataract and Refractive Surgery meetings. And he named it as the Argentina flag sign because it's very similar to the Argentina flag sign, to the Argentina sign. Yeah, there is once you do the initial neck of the anterior capsule, if there is biradial extension of the rhexis, this inside part is the white cataract, white cortex, and this is the bluish anterior capsule with the Virginia blue dye, stained with the Virginia blue dye. So this central white and outside bluish color representing the Argentina sign. It's named by Dr. Daniele Pironi, and since then it's very worldwide known complication of white cataract. However, there is another complication titled as the reverse Argentina flag sign. And this happens if the anterior chamber is overfilled with OVD, ophthalmic visco surgical devices, as described in one of the papers published in Journal of Cataract Refractive Surgery in 2018. And why it's named as reverse Argentine flag sign? Because the mechanism is reversed. The vector forces are the reverse. In the Argentina flag sign, the high intralenticular pressure compared to the anterior chamber pressure will push the fragile anterior capsule and cause this biradial extension. However, in the reverse Argentina flag sign, the high anterior chamber pressure compared to the intralenticular pressure will also push and causing extension of the anterior lens capsule biradially, causing the Argentina flag sign. But because the mechanism is reverse, is titled as the reverse Argentina flag sign. So the main lesson, the main takeaway from this slide, that you should not overfill the anterior chamber with OVD to avoid also the reverse Argentina flag sign, because the high pressure inside the anterior chamber could also extend this fragile anterior capsule biradially. Okay, and this example, the first example about the Argentina flag sign, this was the vector from the high intralenticular pressure. However, here the vector forces from overfilling of OVD lead to extension of the capsule radially. Double peak sign on ultrasonography. So there is a pre-op tricks that make you predict that how much this cataract is intumescent. As we said that pre-operative clinical examination of slit lamp, you can see these sectoral markings and you can see these empty fluid pockets, fluid vacuoles that represent intumescent cataract because it's representing fluid pockets inside the cortex. Okay. However, when you do as we said previously, the intumescent criteria definition, the presence of multiple internal aquatic reflection on the A scan. When you do the P scan, you will find double peak sign on A scan, and this double peak sign representing this sign with the red arrow represent the posterior capsule, and this sign and this peak sign with the black headed arrow representing the posterior margin of the nucleus. So there is a gap between them. This gap represents the fluid accumulation between the posterior margin of the nucleus and the posterior capsule. So this cataract is intumescent and there is high risk of anterior capsule extension. This is what happened in the surgery. Argentina flag sign came again. However, in this patient, there is fluid pockets on the clinical examination, but mainly as we told that this is yellowish, so resorbed fluid happen. Here on B scan with A scan, you see that there is one wave, one full spike without gap between of them, and this one wave represents that there is no fluid trapped between the posterior nucleus margin and the posterior capsule, so the risk of capsule extension is very less, minimal. And this is what happened during the surgery. There was no extension and the rhexis was nice round rhexis. And this double peak sign is a prognostic marker before the surgery for white cataract and was published in the Indian Journal of Ophthalmology 2024. So for patients with intumescent cataract or white cataract, please do for them A scan along with the B scan. Now we'll talk about the role of the anterior segment of OCT, which is becoming the emerging investigation for the intumescent cataract or cataract evaluation. So it can help you in detecting the fluids and the lamellar separation between the lens fibers, thus better planning, better management for the cataract surgery. So this is a normal anterior segment OCT, as we see here, the cornea, the anterior chamber, the lens, the anterior and posterior capsule. However, in this picture of anterior segment OCT, magnified picture on the lens mainly, we see that this is the stage 1 of mature intumescent cataract, with representing the early lamellar separation phase. As we see here that there is lamellar separation between lens fibers, however, there is no bulging of the anterior capsule and there is no fluid collection behind, just posterior to the anterior capsule. The second phase of the mature intumescent cataract is more lamellar separation between lens fibers, bulging of the anterior capsule with fluid collection, but minimal fluid collection behind the anterior capsule. And this represents the established lamellar separation phase. So the phase 1, early lamellar separation phase, there is no risk or very minimal risk for anterior capsule running out. However, in this phase, the second phase, where there is complete established lamellar separation with mild bulging of the anterior capsule and little fluid pockets behind the anterior capsule, there is a risk of anterior capsule running out. However, not as high as the third phase that we are telling now. This is the third phase, which representing the liquefaction, which is there is lysing of all lens fibers, dramatic bulging of the anterior capsule with huge fluid pockets behind the anterior capsule, and this cataract is very, very risky for rhexis related complications. So anterior segment OCT helps you in better planning and management for the cataract. And this patient, as we see here, the anterior segment OCT was done, showing almost established lamellar separations with mild bulging of the anterior capsule, and there's fluids behind the anterior capsule. And this phase, also this picture, however, for the cataract, there is just very mild lamellar separation. There is no bulging of the anterior capsule, no fluids pockets behind the anterior capsule. So anterior segment OCT can help you in preoperative assessment for the cataract. All what we said before about the clinical examination, fluid vacuoles, sectoral markings on the anterior capsule, and also we talked about A scan along with the B scan about the double peak sign, and also we talked about the role of the anterior segment OCT in the management of cataract. All of these are a pre-operative test. There is intraoperative test that you can predict from this test that this cataract is intumescent or no. And this novel observation was reported by Dr. Surab, also very popular cataract surgeon, and from his YouTube video published in his YouTube channel. As you see, when you inject Visco-press test means that you inject Viscot and you press the anterior capsule. So it's a Visco-press test. You will inject Viscot and you will press on the anterior capsule. If there is reflection from the anterior capsule, as you see here, the circular reflection of the anterior capsule, it means that not high intumescence. It means that there is that the intralenticular pressure is relatively not high. And this is the explanation. If you inject any OVD and the intralenticular pressure is normal, when you press the anterior capsule, there will be a reflection from the anterior capsule because against this pressing. Okay. However, if you don't see this reflection on the anterior capsule, this means that the intralenticular pressure is high, that resists the pressing technique from your side. Okay, and this is the explanation also. There is high intralenticular pressure forcing, contradicts, resisting your pressing on the anterior capsule, so there is no reflection like a balloon. No reflection on the anterior capsule after injection of Viscot. So this is intraoperative assessment for the intumescence, for the intralenticular pressure. Is it high or low? It's actually a good observation. The soft shell technique. Now we'll transit. Now we'll move to the techniques that you use in order to overcome rhexis related complications. And one of the best techniques, one of the early described techniques to overcome the rhexis related complication is the soft shell technique. And this soft shell technique is described by Dr. Steve Archino, one of the well-known surgeons in Canada, University of Toronto. He has described this technique 2002 in Journal Cataract Refractive Surgery, long back, in which you use two viscoelastic agents simultaneously, one cohesive and one dispersive, in order to overcome rhexis related complication. Here, that you firstly will inject the dispersive OVD to protect the cornea, and then you will inject the cohesive OVD in order to create space and flatten the anterior capsule. And this technique is very helpful in challenging cataract in general, like white cataract and even like floppy iris syndrome, because the double layers of OVD keeps the iris in space. Also, this technique is very helpful in cases of weak zonules, because it will support the anterior capsule when you make the rhexis, and also the dispersive agent will keep the vitreous, keep pushing the vitreous back not allowing any vitreous to come to the anterior chamber. Also, it's very helpful for myope because the cohesive agent will help you in creating space-flattening capsule and doing the rexes smoothly, and also the space-of agent will help you in protecting the cornea, and also minimizing the cohesive agent will minimize the risk on the posterior vitreous, on the anterior vitreous. So there is a minimal risk of retinal detachment. So this soft shell technique is very good technique. A modified technique by Dr. Steve Arshinov also is the ultimate soft shell technique. Here you will inject 3 layers. What are these 3 layers? The first layer is the dispersive OVD to protect the cornea. The second is the cohesive OVD to create space and flat the capsule, and here you will keep space to inject the PSS. And this the ultimate soft shell technique is very important also in white cataract because it's allow you to inject also the trypan blue dye to stain the anterior capsule. Also, one of the commonest techniques used to overcome rexis-related complication in intumescent white cataract is needle decompression. So you will use now a 27 gauge needle or 30 gauge needle, okay, and you will decompress the lens fibers in order to depressurize the lens cortex. So the technique is that you will inject viscoelastic to deep at the anterior chamber, and also always remember to avoid overfilling the anterior chamber. Then you will bring this 27 gauge needle or 30 gauge needle. You will just do initial neck of the anterior capsule, and you will start aspirating the liquefied milky material. So you will relieve the intralenticular pressure. Then you will do the capsulorhexis. So this technique is mainly to relieve the pressure, the intralenticular pressure, to depressurize the compartment, okay, to release the pressure inside the cortical, inside the lens to the outside by aspirating the fluids using this needle. This is one of the commonest methods used in intumescent white cataract and was described very early in 1999 in Journal of Cataract Surgery. Some doctors and some surgeons, they recommend intumescent lens massage. After doing this initial puncture of the anterior capsule by this 27 gauge needle, they will do massage from the peripheral anterior capsule in order to push the fluids from the peripheral cortex to this central hole puncture, and so relieving the pressure from also the periphery, not only from the center. The modified needle aspiration technique, this procedure was, the needle aspiration technique was modified by Dr. Ariel Blanco, Argentinian surgeon, named as Blanco-puncture technique. Blanco-puncture technique. The main difference from this and the previous technique, the needle aspiration technique, is that you do this needle aspiration before making any cataract incision. So you will not inject Helon or Visco in the anterior chamber. You will just do it under the normal physiologic aqueous humor pressure. Okay, you will keep the eye pressurized as itself. What you will do here is that you will use a 27 gauge needle or 30 gauge needle, and you will do the initial neck of the anterior capsule. Then you will do linear in and out movement. Never ever do side away movements. Don't make, please, side away movement like this, because side away movements increase the risk of capsule running out. However, this linear in and out movements helps in aspirating the lens liquefied milky material without pushing the anterior capsule or putting stress on the anterior capsule. Therefore, no risk or minimal risk of anterior capsule running out. And the main concept or hypothesis of Dr. Ariel Blanco that the main reason of capsule running out or Argentinian flag sign in white intumescent cataract is the pressure gradient difference between the inside the lens and outside the lens. So this pressure gradient difference, even if you fill the anterior chamber, there is a risk of overfilling the anterior chamber, so risk of reverse Argentinian flag sign is there. He's saying that if you do this needle aspiration technique before making any cataract incision, you will keep the eye under the normal physiologic pressure, and the risk for capsule running out is less. And we will see in this video how is the Blanco-puncture
In this
technique
case, we have a complete white
by
cataract,
Dr.
and we are
Mazzetti.
starting to perform the
See,
white
before
cataract
making
surgery, trying to avoid the
incision,
Argentinian
corneal
flag
incision,
sign.
side
So
incisions,
the first
directly
thing that we
using
do
27
is going
gauge
through the
needle. We'll do
limbus
the
with a
initial nick of
30G
the anterior
needle,
capsule
entering the
and
anterior
aspirate.
chamber, and then
You
making a
see here
puncture in
the
the center
liquefied
of
milky
the
material.
anterior capsule.
You will
With this
aspirate
maneuver,
the
what
liquefied
we do
material
and
and
expect
doing
is
in
that the
and out
content of the white
movements
cataract
of
goes
the
out
needle,
of the
not
bag
side-away
to the
movements,
anterior
okay?
chamber in a
And
very
that's it.
gently and
Then
soft
he will do
way.
the incision and
Doing
he will
that,
do the
we try
rexes.
to avoid the Argentinian flag sign.
And this maneuver will help in releasing the intralenticular pressure, so depressurizing the lens from inside. Another technique, a modified also technique for the needle aspiration technique that we described earlier, is the anterior chamber early pupil technique. This technique has been described by Dr. Wang and his team using air pupil along with this needle aspiration technique to release the fluids. So what you will do here, that you will make incision, small incision, you will inject some of viscoelastics, not overfilling, just some of that, then you will inject air bubble. And this air bubble will counteract the high intralenticular pressure, will resist the high intralenticular pressure, thus reducing the risk of capsule running out. Then you will you will do the initial nick of the anterior capsule and you will aspirate the milky fluid liquid, and they recommend you push the lens backward in order to release the fluids from the posterior surface in order to get out the to the anterior chamber, thus releasing the liquefied milky material. They included 50 eyes, none of them experienced Argentinian flag sign. However, this study is still a preprint and not yet published, so their technique should be taken with caution. Dr. Gimbel also described one of the commonest methods or techniques to overcome the Intumescent cataract is the two-stage capsulorhexis or double-stage capsulorhexis or snail track capsulorhexis or orange peel maneuver. Okay, all these are the same technique, different names for the same technique. And this technique was described very early in 1990 in Journal of Cataract and Refractive Surgery by Dr. Gimbel. What you will do here, that you will do small rhexes after injecting viscoelastic in the anterior chamber. You will do small rhexes, then you will enlarge this rhexes using small scissor, Venus scissor or rhexis scissor. You will enlarge it tangentially as a snail track. You will see here the snail track appearance or orange peel appearance. Then you will extend it after doing the small rhexes. Then the liquefied material will come out, so the intralenticular pressure will be relieved, and then you will do the second stage of the rhexis by cutting the capsule periphery using Venus scissor and complete it as the usual. And this is why they call it snail track appearance, because it's the same as the snail track. Its article published in Asia Pacific Journal of Ophthalmology 2021 discussed the role of preoperative YAG laser anterior capsulotomy for Intumescent cataract. They said that because there is a risk intraoperative of capsule running out. Why we don't do a preoperative YAG laser anterior capsulotomy? So we release the pressure from the inside the lens fibers and reduce the risk of Rex's related complication. What they do that they do YAG anterior capsulotomy using one shot, 1.2 millijoule. They included they included 52 eyes. One patient only, 1.2% of the patient developed the Capsulorhexis extension. Otherwise, most of the patient, more than 98% of the patient, none of them had Rex's related complication, Rex's running out. And as you see here, this is the anterior chamber depth compared with the lens thickness. After one shot of YAG laser, you see the deepening of the anterior capsule 1.6 millimeter to 2.25. So deepening of the anterior capsule along with release of the milky fluid pockets from this capsulotomy. Dr. Prasad and his team also described a very novel new device, new capsule needle technique in order to overcome the Rex's related complication, and their study was published in Journal Cataract Refractive Surgery in 2011. What they did there, they reviewed many videos about Argentinian flag sign complication, and they noticed that when you do the initial break of the anterior capsule using the 26 or 27 or 30 gauge needle, this linear cut usually the main leading point for the biradial extension. They said that all of the cases there is extension radially, there is no any extension perpendicular to this cut. So this linear cut helped in this propagation due to the high intraventricular pressure, propagate this cut into biradially, causing the Argentinian flag sign. So they came up with this theory that if they do make a needle with a round pointed tip, this will make round hole, round cut with round margins that can resist this intralenticular pressure and the fluid thrust from the bag. So they compare, this is the linear cut made by the 26, 27, 20, 30 gauge needle, and this is the cut they made. They brought sewing needle and they modified with many experiments, and they ended up with this sewing needle microcapsulotomy. It's a small capsulotomy device or needle that make round capsule, and this is the as you see hook of the needle with angle 60 degree with rounded pointed tip that help you in doing a round hole or round cut instead of linear cut. And we see that this is the first cut of this capsulotomy needle, and you can also make a star shape 1, 2, 3, 4 to distribute the pressure on the anterior capsule, preventing the Argentinian flag sign from happening. Because when you distribute the pressure, you will release the liquefied materials from the bag, and you will help distributing the pressure, so no propagation or running out of the Rexes. Dr. Mahajan and his team also, they described a novel technique for dealing Capsulorhexis and Intumescent cataract named as Vaccum Capsulorhexis, and published in the Journal of Ophthalmology 2022. What they do that they make one incision, only single port incision, and they will inject air bubble and they will send the anterior capsule. Then they will do the initial break of the anterior capsule with 24 gauge cannula attached to 10 millimeter syringe with manual vacuum force, and this vacuum manually adjusted by the surgeon. So they will aspirate the fluid and they will raise the flap, and this 24 gauge cannula attached to the 10mm syringe, it will manually do suction on the flap and raise the flap and continue the rhexis circularly and circumferentially. And the main benefit of this rhexis that there is only single incision, so better anterior chamber stability, and also this suction on the flap will keep the rhexis and resist any running out of the rhexis peripherally. However, the main challenge also there is a benefit that there is no need for any special instrument, like for example sewing needle microcapsulotomy. However, the main challenge is that there is a challenge on how to control the suction force on the flap, also maneuvering this 10mm syringe. So there is maneuvering challenges during doing this capsulorhexis. However, it's simple and can be performed by surgeons. A similar technique was also described by Kodavor and also published in the Journal of Ophthalmology 2022. Can-Vac technique. Can-Vac means cannula, vac means vacuum, so it's a cannula attached to a manual vacuum, a 5 ml syringe or 10 ml syringe, and this vacuum will be controlled by the surgeon. After aspirating the fluids, he or she will hold the flap edge and do the rhexis. However, Can-Vac star means star, so you will do multiple breaks. You will do the initial break like this, like this, like this, in order to distribute the force vector, so none of these stairs will run out, will propagate because of the bag thrust. So you will do multiple breaks in a star shaped or star fashion. Then you will bring this cannula, 24 gauge needle cannula or 25 gauge needle cannula attached to a syringe with a manual vacuum. You will hold the flap and you will continue the rhexis. And this is how is the cannula attached to 5 ml or 6 ml syringe. This is a video also about the technique. The anti-capsule stand and only one incision, multiple breaks, star shaped as we said, so you will distribute the forces on the anti-capsule, preventing any of them from propagating to the periphery, already causing Argentinian flag sign or rhexis extension. Then you will bring this cannula attached to the syringe. You will hold, raise one of the flaps, and you will hold the suction. You will keep holding the flap edge and doing the rhexis on a circular fashion or maneuver, as you see here. Continued this rhexis using the star Can-Vac Capsulorhexis technique. So the main benefit that there is only one single incision, so better chamber stability, there is no special instruments, surgical instrument to use. But the main drawback is the challenging maneuver, this cannula attached to the syringe, and also the risk on how to control the flap using this suction. Dr. Ting and his colleagues also described another technique to overcome or to manage anterior capsulotomy for Intumescent cataract, and they name it as Phaco capsulotomy, because what you will do here that the initial puncture of the anterior capsule will be performed using the Phaco probe, the usual Phaco probe. You will take the Phaco probe and do the initial puncture of the anterior capsule, and directly you will start aspirating the liquefied material from the cortex and depressurizing the capsular bag. After that, you will take the rhexis forceps or cystotome to complete the rhexis. However, actually this maneuver or this technique, Phaco-capsulotomy, has main disadvantage, and this disadvantage is the unpredictable capsular opening, because the initial puncture of the anterior capsule will be using the Phaco probe. So there is unpredictable capsular opening. Also, there is risk of zonular dehiscence if you are putting downward pressure on the anterior capsule, or you are using vacuum pulling the anterior capsule, putting the stress on the zonules. So there is a risk of zonular dehiscence, and also there is a risk of wound burn if you embed a hard nucleus and you keep pushing on the third pedal. There is a risk of corneal wound burn. So this is Phaco-capsulotomy is also one of the reported techniques to overcome the rhexis-related complication in Intumescent cataract. Also, one of the recently reported techniques published in the Indian Journal of Ophthalmology 2024 is flow capsulorhexis. What we mean here by flow capsulorhexis, that you will use two pen cystotome, and you will attach this cystotome to PSS line infusion. Then you will do the rhexis under this continuous inflow of the PSS. So you will continue the rhexis with keeping the anterior chamber stable because of the inflow infusion of PSS, and also washing out the liquefying material released from the cortex through the PSS line infusion. So this technique, in this technique, they included about 300 patients with Intumescent cataract in each group. Group 1 was with this flow capsulorhexis technique, and the second group was with the needle decompression technique, and they found that the success rate for the continuous circumlinear capsulorhexis is 95.8%, almost 96% in group 1 who underwent flow capsulorhexis, and about 87% in group 2 who underwent needle decompression technique, and this was statistically significant. And also they noted that the rhexis doing the rhexis is much faster in group 1, the flow capsulorhexis, compared to the traditional technique, needle decompression technique. Also, there is less OVD supplement in group 1 compared to group 2 because there is a continuous infusion line of PSS. So this technique, it's cheap, there is no need for special instruments, faster because you are touching the line of PSS infusion continuously during doing the surgery, and there is no need for extra steps to go out from the anterior chamber to enter and coming back and forth, so you maintain the anterior chamber stable during the surgery. And this is the technique described by them, and this is the video showing how is
here we attach the two bent
technique.
cystotome to the
Here
infusion
you
line
see the
of
infusion
balanced
line
salt solution
of PSS,
instead of a
and now
syringe.
the surgeon will attach this infusion line to
And the flow
the
was kept
cystotome,
open. I will
and then
demonstrate the
you will
technique.
do the
The CCC was performed with the
capsulorhexis
continuous
and
inflow of balanced salt
the
solution.
initial break
The
now
continuous flow of
directly.
fluid washes out the
Now
liquefied
you
loose
see here the
cortical
liquefied
matter
material
without
coming
allowing the
released
anterior
from
chamber to
the
collapse or become
capsular
shallow.
bag,
Also, the
depressurizing
visibility is
that
not hampered,
through
and the
washing
surgeon
out
can
of this
continue the
material
capsulorhexis without
using
withdrawing
the
the cystotome
continuous
from
line
the
infusion
anterior
of
chamber
PSS.
or injecting
However, as you
viscoelastic.
see here, because
The
it's
flow
under
can be
PSS
manually
infusion,
controlled also
the rhexis
if
is
needed.
not stable as under OVDs, Elon or Viscot. However, it's a reported technique, very recently reported, and this surgery was done in Sankara
That
Hospital.
completes the CCC. As you can see, it is a very
FLC, femtosecond laser capsulotomy. Dr. Friedman and his colleagues in 2011, they evaluated femtosecond laser for doing capsulorhexis in cataract surgery, and they named it as femtosecond laser capsulotomy. And in their study, they concluded that femtosecond laser capsulotomy is more precise and accurate and reproducible and stronger than those created with the conventional manual technique. And their study was published in Journal Cataract Refractive Surgery. And as we see here, this is a device, femtosecond scanning laser, doing the rhexis from the name femtosecond, 400 femtoseconds. So it's a pulse of the second, not complete second. Also about 10 millijoule energy. It's very accurate and very reproducible. And we see in this image, post-operative image, the difference between the accuracy of and precision of the rhexis performed using the femtosecond laser capsulotomy compared to the conventional manual technique. However, the main drawbacks of femtosecond laser capsulotomy is very expensive and also requires supplemental patient payments. Patients need to pay more in order to use this device. Also, it disrupts the normal operative workflow because it's a large device. Actually, it needs 2 rooms, so the patient usually go to the room with femtosecond laser capsulotomy and do the rhexis and the first steps of cataract. Then he will be shifted to the other room to continue the cataract surgery. So it's disrupt the normal operative workflow. Dr. Chang and his colleagues described the Zepto pulse capsulotomy 2016. They call it Zepto precision pulse capsulotomy, and they concluded that there is no differences between group 1 and group 2. Group 1, which is the traditional manual rhexis, and the group 2 Zepto in the post-operative corneal edema inflammatory reaction, the capsulopacification or PCO, capsulopacification. This device, Zepto precision pulse, composed of, as we see here, there is a control console attached to the handpiece tip, and there is foot switch to to run the handpiece or to emergency stop it or stop it. The handpiece, from below view, you can see that there is nitinol alloy housed in silicone suction cup, and there is a push rod that help you in entry to the anterior chamber. So this device would actually do that. This nitinol ring inside the silicone suction cup. Once you enter this Zepto precision pulse device into the anterior chamber, it will convert, and you turn it using the foot switch. It will convert the electrical pulses within 4 milliseconds to mechanical power that cut the anterior capsule, and it's very fast, very from the name pulse, very fast like a pulse. So there is no any heat dissipation released outside this nitinol alloy memory within this silicone suction cup. Also, it's very precise, and actually it's very recently reported novel technique to prevent any intumescent cataract rhexis related complication. And we'll see here the video how is the Zepto precision pulse capsulotomy. You will push through the push rod the Zepto device inside, then you will retract it so it will open, and then you will push on the foot switch. So within 4 milliseconds you will do the capsulorhexis. It's very precise. Then you will just remove this anti-capsule remnant, and that's it. It's very good actually device. The last technique about the treatment or dealing with the capsulorhexis related how to do anterior capsulotomy and intumescent cataract is using selective laser capsulotomy, CAPSUlaser. And it is very recently reported device. It gives you more accurate sizing, more accurate circularity, and more accurate concentration of the laser capsulotomy compared to the manual one. And this study was published in Journal Cataract Surgery in 2019. And also comparing selective laser capsulotomy to femtosecond laser that doesn't need this disruption of the workflow of the patient because it can be applied to the same machine, Phaco machine, attached to the same Phaco machine. Another thing that comparing head-to-head femtosecond to selective laser capsulotomy revealed that 10% of eyes underwent femtosecond laser capsulotomy can have 1 to 2 clock hours of anterior capsule attachment, and these 1 to 2 clock hours attachment are potential sources for capsule running out. However, in this selective laser capsulotomy, it's more precise, more accurate, and faster in 1/3 second. 3.3 seconds will finish this rhexis. However, the main disadvantage of this selective laser capsulotomy is mainly the cost. And this is one of the surgeons, Dr. Hassan Khalid, do this selective laser capsulotomy. It's very quick, very fast, very rapid.
Rhexis is 5.3 millimeter, and you can see is concentric with the central tribal landmark, and you can.
So we finished this lecture presenting all the techniques reported in the literature. I summarize all the benefits and disadvantages for all techniques reported in the literature in this lecture. I hope that you find this lecture useful in your career and in your training, and this is my advice for you all.